Welcome to Action on Pain, a podcast dedicated to highlighting the significant efforts underway in Canada to address chronic pain.
By presenting perspectives from individuals who live with pain, researchers, clinicians, and other stakeholders, we explore various impacts on people's lives and the initiatives, research endeavors, and the committed professionals working to effect meaningful change.
This work is guided by Health Canada's Action Plan for Pain. Join us as we raise awareness and share stories that are shaping the future of pain management in Canada.
Well, hello, everyone. Thank you for joining another extraordinary Action on Pain podcast. I am Virginia McIntyre, joining from Nova Scotia, and I'm joined by my talented co-host and friends, Jennifer Daly-Cyr and Keith Meldrum. We have a special guest for you today, someone that I had the pleasure to do my Pain and Society Fellowship with and had the opportunity to get to know very well over the last couple of years. So this is going to be an exciting podcast I'm looking forward to.
It's great to see everybody. It's Keith Meldrum. I'm joining everybody today from Kelowna, British Columbia. It's always great to join everybody here from the West Coast. I'm the West Coast representative of this little podcast. So it's been a little while since we've had a chance to record. So Jen and Virginia, it's really good to see you again and really excited about having our conversation with Dr. Di Renna.
Yeah, and I'm the kid in the middle. I'm extremely excited today to welcome our next guest, who is someone that I met through the Canadian Pain Society, and then we were co-board members of Pain Ontario, and as a fellow Mayday Fellow. Today, we are very pleased to welcome Dr. Tania Di Renna. Dr. Di Renna is an associate professor at the University of Toronto, Department of Anesthesiology and Pain Medicine. And she completed her medical school and anesthesiology residency training in Ottawa. She obtained a chronic pain fellowship through St. Michael's Hospital in Toronto. Dr. Di Renna is the medical director of the Toronto Academic Pain Medicine Institute, which is called TAPMI. TAPMI is the largest pain partnership that includes 5 academic hospitals in the Toronto area. She practices anesthesiology and chronic pelvic pain at the Women's College Hospital. She served as the co-chair of the Health Quality Ontario Guidelines for Chronic Pain and co-chair of the Ontario Chronic Pain Network. She is a board member of the International Association of Pain, Abdominal and Pelvic Pain Special Interest Group, and it is also very special that she is now the president-elect of the Canadian Pain Society. Dr. Di Renna, it is such a pleasure to welcome you here today on our podcast.
Thank you so much. Thanks for inviting me. It's a real honor to be speaking on the Action on Pain podcast, and triple honor to be speaking to 3 of my favorite faces when we go to meetings to see, because your contributions to what the future of pain looks like are invaluable. Seriously, we always make this joke about the Pontiac Aztec, which is a really, forgive my mouth is kind of salty sometimes, but is a really crappy car because they never ask anybody, would you drive this, right? And so I feel like without people with lived experience, if you make a car and don't invite these people to co-design it with you, you will create a wonderful Pontiac Aztec and nobody will buy it. And so,
Okay, I love that.
So this is what I think about why this is so important that I'm here today.
Oh, that's great. I love that. And if anybody who's ever seen a Pontiac Aztec,
They had the little camping thing on the back. There was all of that going on.
No, they didn't ask anybody about who
You're going to have to remember that one. That was great. Well, thank you for your very kind words. So let's just launch right in here. We know this is going to be an amazing conversation. So in the opening here, Jen shared that you're the medical director of the Toronto Academic Pain Medicine Institute, or TAPMI, which is currently the largest academic chronic pain partnership in North America, which is unbelievable. So would you like to share how the TAMPI model of care supports the achievement of one of the specific goals, which is goal 2 of the Action Plan on Pain for Canada, and just how you see really that work, supporting what the Action Plan does?
Yeah, thanks. So what TAPMI is a partnership. So what happened is in the downtown core, there's like 5 very big institutions in the GTA, and we're all quite close to each other, but we were running very independent pain programs. And so we got a pocket of funding from our Ontario government. So thanks to them. But instead of parceling it out, we all came together to work like one big pain center, which takes a lot of effort for me, but also even for the people who are running those independent centers, right? Some of these centers have been around for 30 years. You build a reputation, and now you kind of have to come together with other newer centers, et cetera. So what we did is we created this central intake system so that if you're a family doc in Ontario and you're referring to downtown Toronto, you don't have to use a specific referral form for each institution. You can just use one referral form. And then we can look at all the wait lists. And depending on the urgency of the patient and the wait list, we can actually make it easier for patients and decrease wait list time by sending you to the lowest wait list. And then while you're waiting on the wait list, we do a lot of things. We have within a week of being referred, we have what's called a mandatory orientation, which we do because we do it mandatory and we have a huge, we recognize there's a lot of access issues. So we do this one-on-one, we do it over the phone, we have interpreters. So you don't necessarily have to be good with technology. We can kind of cater it towards whatever you need. And the reason why we did that is because we wanted to make sure people understood why they were being referred. Because a lot of people get referred to a chronic pain center and they don't even know they have chronic.
Oh,
They're never talked about. No one's ever talked.
That was my case.
Yeah. And so you're often the first person breaking the news to them.
Mhm.
And so we wanted to make sure, it's one of those specialties that this only happens really in our specialty. Like when you go to an orthopedic surgeon, you kind of know that you, you may have an issue with your hip that requires surgery, or an oncologist, you may have cancer. So when people come to us, they have no idea often why they're seeing us. And so we wanted to give them some upfront education, but also some upfront resources and data collection. So we have that orientation also for data collection. So the beauty of that data collection is it let us do so many things. And sorry if I'm talking too much. You can interrupt me. But first of all, the upfront resources like power over pain. We created a self-management program in Ontario that's offered like 3 or 4 times a month that's led by lay people. And so we give them access to that. Tell them sign up for this while you're waiting. That way, at least you'll learn some self-management skills. We're starting to incorporate empowered relief from Pain Canada. So we're trying to give people a lot of upfront things so that even while they're waiting, they have resources that, are Canadian based, relevant to us, and created by all of us from Pain Canada, right? So we all belong to Pain Canada. So the other part was the data collection. And so Rachel Bosma is our scientist here. And so we collect a lot of data, and the data gets used to create the programs. So we don't hire folks unless they serve this need or this population, right? So it's not just like doctor-centric care where this person has this fancy fellowship and they get hired and 3 people really need these services. It is like, hey, the community is telling us that we got to know about young adults. So someone's got to get a fellowship in young adults, or someone's got to get a fellowship in pelvic pain. And so it really allows us to be a learning health system, right? So collect the data and create the system to respond to the data. 70% of the people that walk through our doors are women. We had 80% male docs. So our strategy for the last 2 years is we are saving spots for female providers and BIPOC providers, because a lot of our patients are Black or people of color. And so we want them to understand that we recognize this and we want them to feel comfortable when they walk through our doors. So this is the kind of thing a central intake system does. It allows you to be very nimble.
That was amazing. I was just going to say this upfront system, with the education, that must make them more ready by the time they see the clinician to really get their feet on the ground and move forward. They must be kind of be in that momentum already.
You know what, Virginia? Some of us as healthcare practitioners in the medical field are terrible at delivering news about chronic pain and explaining it. And then when you go to the Pain Canada, when you go to Power Over Pain website, and there's all those videos that explain pain by people who are trained to do this and do it very well, I think the delivery is so much better. And then there's also resources, because when people are suffering, the best resources to give them is community, right? And so that's where this People in Pain Network comes in. That's where your important work comes in to say, hey, you know what? You're actually normal. This is 1 in 5 Canadians. That's a bigger problem than you think.
I love that normalizing it. And I just wanted to take a moment before somebody else jumps in here. When we talked about goal 2 for our listeners here, that goal specifically says it's to improve equitable access to timely evidence-informed, person-centered pain care. So everything that you've explained, that's goal 2. I mean, you're doing everything to get people in, make it equitable, evidence-based. I mean, talk about a perfect example.
And so thoughtful around who your patients are, what the demographics are, and really kind of considering that whole picture. And so that's more than the symptoms of pain you're talking about. That's the whole person that walks in the room. And to Virginia's earlier point also, it strikes me that having patients better prepared walking in the room probably really economizes on time, or maximizes rather the effectiveness of that time that is allocated to see the physician and have their chat, so they're coming in better prepared.
Yeah, I think, there's always more room for improvement, right? Because I think that for chronic pain patients, the medical system traumatizes everyone so much. You're used to walking into a room and being told, we can't do anything for you. We don't know what's wrong with you. Because I think sometimes medicine, when we don't understand things, we blame the patient in front of us rather than saying, hey, like, we got to do better. Why don't we know this? Why haven't we researched this? And so, yeah, there's something we can definitely do better. In terms of evidence-based, I think you touched on this very well, Keith, is that we're also trying to, central intake systems, what they do is they also kind of hopefully route people towards you rather than there's a lot of pain clinics out in the community that are very focused on one type of management, which is like an injection. In certain provinces, there's lots of pain clinics that are run by radiologists who do injections, et cetera. Not necessarily folks who have training to understand that those types of therapies are important like 20% of the time.
Right.
Like you need the other piece, right?
Yeah.
So diabetes is not just about taking insulin. Diabetes is about sleep, good eating habits,
Right.
support from your family, support from your family physician, and having a good schedule so that you can live longer. And I always feel like chronic pain is the same, right? It's not getting an injection that's going to cure you.
That's brilliant. You talked about as people are preparing to come into the clinic and before they actually see, a physician, they go through pain education. So self-management modules or education. Have you found, I've heard this from some people that when they have those opportunities, because like you say, first of all, they're never told that they have chronic pain really, and they don't know what it means. So they get this education. Have you found that some people find that greatly helps them with their pain and that their interaction with now the healthcare system might actually be less because they're like, hey, there's a bunch of things I've now learned that I can do to help myself. So maybe their impact on the system has been lessened.
I've seen it. I've seen people who don't have the mandatory orientation and people who do.
Wow.
Yeah.
And it's two different conversations. And, one person comes in very frustrated and the other person is kind of a little bit more ready. But, you have to meet people where they're at, right? So not all people are ready to accept that this is going to be forever. I can tell you, I work with women. So I can tell you that when you are constantly dismissed, I see a lot of women with endometriosis who've had endometriosis since they started menstruating and all this pain. And then everyone's constantly dismissed, right? And so their perception of the healthcare system or being told this is the rest of your life will make them very angry because there's a sense of injustice there. Maybe the trajectory would have been different had somebody diagnosed this like appropriately 10 years ago. Maybe they wouldn't be infertile. So you also have to meet people where they're at and be really respectful. Even sometimes the anger is taken out on you. You have to understand that this is a system that's made them behave this way. And the fact that they've been dismissed for so long that now you're telling them, hey, like you're going to have to live with this forever.
I just love the fact that it is that social, spiritual perspective that, as you're describing, it strikes me as the priority for TAPMI. And, coming from my own experience, I actually suffered for years with endometriosis without realizing it was considered chronic pain. But also in this version of what I'm with right now in terms of abdominal pain, completely different. It was a year and a half to get into the clinic after I was referred. I likely had been told that there was something chronic about this, but I didn't know what it was, the root cause. And I was waiting to be fixed. And I didn't have any resources. It was before the stepped care. It was before all of this. So like some 11 years ago. And while most of my doctors were working very hard to find it, I nonetheless was waiting to get to that pain clinic to be fixed. When I reflect back on that, it's kind of an odd way to look at it, knowing what I know now. But that's the power of information and power of building knowledge, right? So good on the you and the TAPMI group for creating that potential for people early on.
Yeah, I really resonate with that as well. And I'm just going back to something you said early on, Tania, when you talked about you got funding from the province of Ontario, and there's 5 major hospitals. How did you overcome the bureaucracy and the politics of 5 different organizations deciding to come together and say, let's work together? Because I don't think
naughty.
that's common.
You're naughty.
I'm interested. I'm interested. That's a tough nut to crack.
So tell me about what the question is, just so I can think of a response.
So you were funded 5 major hospitals who were all focused on this, and instead of the funding being carved up and say you get your 20%, you came together as a group and said let's work together this collectively. And I haven't seen a lot of that.
That's funny. I also give a talk about like the Disney princess. I don't know if you guys have ever seen that. I put like the Disney, the guys who I work with, all their faces on these princes. They're wonderful people. And unfortunately, when you work at academic institutions, people, in order to get promoted academically from assistant to associate to professorship, you have to put your name first on things and ideas, right?
Yeah.
And so this very weird behavior that doesn't encourage people to work together.
Right.
Yeah. And so that's hard. That's what you're beating. You're beating a system like a university system that's been around for over a century. And so, now you have to change that mentality. But the real way things got changed is through common goals, right? Just a little bit at a time. There's a great team here that we do studies together, and we share studies, and we share putting our names on ideas so that people don't feel like they're being left out or taken over. But we also come to agreements based on whatever the evidence is. So we'll have a lot of our learners present the evidence to us and say, hey, this is the best way to do it. Let's all do it this way. So if you can kind of use a leadership carrot that's based on education and a common goal, then you'll get a lot of agreement. A little bit at a time. And I know I came in like a bulldozer. It was bad. Don't do that. Come in self-depreciating, funny, and then things will work. I wanted to highlight 2 things because I don't want this to escape. Yeah. The mandatory orientation also presents our health disciplines first, right? And so people are always fixated on seeing a physician. And as we know, that biopsychosocial model, 66% of it depends really on the people who do the movement well and the psychological interventions well. And so those health disciplines are way more important than your docs. And so this is why it's important to show people with chronic pain, hey, these are the people that are really going to help you, right? Not always us. So health discipline's important. The other part that Jennifer said really, really well was I didn't know endometriosis was chronic pain. And this is why that diagnosis and measurement of chronic pain, we've been under measuring it forever. And if you look at the ICD-11, if we really call things what they are as chronic pain conditions, then we'll really get an idea about how big the problem is. Because if we don't measure it appropriately, it doesn't get funded, right? So this is also an issue, right? We should be measuring endometriosis as a chronic visceral pain condition, right? So this is also important. And it is also important in central triage. Like, what are the diagnoses that we're dealing with?
I hear that. Well, I always say it's more than one. That people with migraines will say, I don't have chronic pain. And so I truly believe the numbers are more than 1 in 5. And that's, we need to measure it more. And then if we do look at these conditions as chronic pain, maybe they will be referred to organizations like TAPMI and these other organizations. And I know down in time, but I like to talk about, you talk about this connection with 5 hospitals, but I know we've shared before about the hub and spoke program. So you actually are connected across the province. Is that not correct?
Yeah. So the way the Ontario Chronic Pain Network is that there's the Ministry of Health in Ontario funded 19 pain programs now, and they're all affiliated with an academic institution. So the University of Ottawa and the Ottawa Hospital Pain Clinic, those are all funded programs. Kingston, London, Hamilton. There's Sudbury, Thunder Bay now has a PEDS program and an adult program. So we are all together with what's called the Ontario Chronic Pain Network. But that is just directors, administrative and medical directors. We all try to work together and have some unity in how we're delivering care. We all talk, we share resources, which is really great. But it is missing the person with lived experience piece, and it is missing the research piece. So that's why Pain Ontario was developed with the help of Pain Canada. So you need all those 3. You need like the medical leaders, the health disciplines, but you also need the person with lived experience and the researchers to all be talking together. That's what institutions like Pain Canada and helping to create in Ontario help do. It would be nice if we could all be under one umbrella, but I'm not quite sure we can do that here yet.
I just, going back a little earlier to, you talked about how you made this happen in Ontario with the 5 hospitals. I just love the fact, and this is me being a big nerd, so forgive me, it's about the evidence. It's not about personal egos or, my way is the right way. It's having everybody come together and say, like you said you agreed that this is the right way to do it, and then everybody does it. So I think we need to see more of that. We're getting to see more and more evidence in pain care. We just need, I think, more and more people to follow that evidence to where it takes them. So that's amazing. I think it's just incredible what you've been able to do.
Well, I think it gives us hope for the rest of Canada and the other provinces to, either model what you're doing or copy pieces of it, because things are happening in Ontario. So it is quite impressive.
Right. Like, I'm very proud. I love my job. It is my reason for being. I like finding gaps and saying, hey guys, we're missing the boat here. We have to do this first. And just, parceling it out a bit. And so that's my hopes for the strategy for Pain Canada. It's like, let's take little pieces over the next 2 years and try to parcel it out a bit.
And I love that as well, because if you can't tackle it all in one go. So, and this is a marathon, not a sprint, right? It's got to be a long run. So we got to save our energy and make sure we're in it for the long haul. So
make it sustainable.
Well, thank you, Dr. Di Renna. This has been amazing. Thank you for sharing your time and expertise with us. I know we have lots more to learn from you, and we'll hopefully have you come back again. Thank you so much.
Thank you for changing the way, I think the trajectory of pain in our country is going to change from you people, right? This is your time. We so value all of your contributions, and we understand you're people that live with pain, never heard you complain, always managed to do everything, just like paid folks. You do all this great work for us, and so it does not go unnoticed. So thank you so much for the next generation. Thank you on behalf.
That means so much. And it is, I'm sure I can speak for Virginia and Keith. And it's a pleasure to be able to, and a real honor for us to be able to do this work and to learn from you and others.
Mm-hmm.
And we'd also like to thank all of you for tuning in to the Action on Pain podcast. We hope this episode has shed some light on the important work being done in Canada as guided by Health Canada's An Action Plan for Pain in Canada. Until next time.
Thank you for joining us today on Action on Pain. If you enjoyed the discussion, please follow us on your preferred podcast platform to stay updated, and please share with your networks. A 5-star rating and review would help others find our show. Your feedback is important.
This podcast does not contain any medical advice. Please consult with your doctor if you have any questions or concerns.
The Action on Pain podcast is made possible by the generous support of the Chronic Pain Network, a national research and knowledge mobilization network.
The views, opinions, and content shared by hosts and guests are their own and do not necessarily reflect those of the Chronic Pain Network or its funders.